apologize. Precision population health, as we describe it, we think about as above the skin but within the walls. Population health has nothing in its definition that limits it to healthcare systems, but the way it's practically being implemented within medicine at least is that it occurs within the walls of the healthcare system. It is disease-oriented, does include health behaviors, nod to environment, and importantly, a focus on policy. Precision public health we think of as above the skin and outside the walls. Social determinants of health. It is health-oriented rather than disease-oriented, community-based interventions. It is focused on place and equity. It is also focused on intervention. Part of the definition of public health includes intervention. It's not enough to use precision public health in order to identify problems, but it has to be used to intervene in a tailored fashion as well. So precision medicine is where the resources are going. The All of Us research program is a million-person cohort that is being established by the NIH. It will focus on the genetics of that group. It will attend at some level to environment and lifestyle. But the way it will do it is by asking the people self-reported questions about their lifestyle and the environment, which is only a poor proxy for the reality of their experience. Precision medicine includes very little language or consideration of public health, and through many sources is not predicted to impact overall morbidity and mortality, at least not for decades. Health inequalities, inequities, social determinants of health are largely left out of the Precision Medicine All of Us research initiative. Precision population health, functionally, as I mentioned, is expressed in healthcare as health systems populations, not whole populations. And we look at population health, precision population health, as a potential neutral arbiter, interrogator that can combine synergistically the healthcare triple aim and the public health triple aim. It can attend to electronic health record, genomic, environmental, and wearable data, which brings it out into the community, while the public health side can take data from health departments, place, socioeconomics, and we'll share with you some ideas about using the Internet of Things in order to gather data for public health surveillance. The Internet of Things refers to the connection between the electronic devices that are so prominent in our lives today. Anything from your phone to your car to your voice assistant Alexa or Siri or Google Home or whatever. Your refrigerator, your washer, your dryer all have electronic chips in them that theoretically can communicate with each other. And the Internet of Things is seeking to enhance that communication in a manner that improves, on our side, that improves health and improves health surveillance. We'll talk about that more later. So precision public health has been described as the application and combination of new and existing technologies which more precisely describe and analyze individuals and their environment over the life course to tailor preventive interventions for at-risk groups and improve the overall health of the population. I've put that asterisk there to point out that we and others feel that new and existing technologies are not enough. New and existing technologies and other approaches. There are new approaches that are not technological that can complement the tech approaches. Again, precision public health is not discussed in the Public Precision Medicine Initiative and calls for modernization of surveillance, epidemiology, and information systems in order to advance precision public health. Precision public health would involve the application of these precise technologies and interventions through comprehensive health platforms, through artificial intelligence in the home, including Internet of Things technologies. We refer to these technologies as surroundables, placing them in contrast to wearables. Wearables are an individual device that can be aggregated and used for population health benefit. Wearables are things like your Fitbits and any thing you put on your body that monitors health. The surroundables represent things that would be in your environment that help monitor health that can be then disaggregated for individual benefit. So we think of surroundables as a public health orientation and wearables as more akin to medicine. There is also a lot of promise in the future of gathering health data, including social media mining and a variety of approaches in addition to the Internet of Things. Precision public health explicitly places emphasis on health inequities and social determinants of health, includes targeted interventions based on findings, and I will say advocates for what has been described as a new power approach. New power has been described in a recent book by Hymans and Timms in contrast to old power. Old power is held by a few. New power is made by many, and it's most forceful when it surges. Old power works like currency. The more currency you have, the more powerful you are. New power works like a current. The higher the current, the more powerful the current, the more powerful the change can be. New power, or old power, advocates formal governance, managerialism, institutionalism, while new power is informal, networked governance, self-organization, opt-in decision-making. Old power focuses on competition, exclusivity, resource consolidation, while new power focuses on collaboration, crowd wisdom, sharing, and open sourcing. Old power is explicitly confidential. Discretion, separation between private and public spheres are all emphasized. In new power, we look at radical transparency. Expertise, professionalism, and specialization are all part of old power and part of this room here. We are experts, we are professionals. Many of us have specialized in different areas that impact public health. But in new power, it's a maker culture and a do-it-yourself ethic. Long-term affiliation, loyalty, and passive participation are hallmarks of old power, while short-term conditional affiliation, active, involved participation define new power. Now, this is not to say old power bad, new power good. It's to say, again, they're complementary and reciprocal, and we can use aspects of each of those in order to accomplish goals that we cannot accomplish only with old power, and that others are already accomplishing with new power. Anybody want to give me an example of how new power is working in our society right now?
Trump and China.
Okay.
Twitter revolution.
Sorry?
Twitter revolution?
The Twitter revolution?
Yes. Open source coding.
Open source coding, yes. Me Too, Black Lives Matter. Most of the social movements of our time are, in fact, new power movements, including the ability of ISIS to recruit adolescents from the United States. They use new power. They don't use old power, including Trump's election victory, where he used new power to gather resources rather than old power. In fact, it was placing himself in contrast to old power, whether that's true or not, that attracted many of his supporters to him. So new power and old power. So I promised I'd give one more disclosure today. I'm going to do that right now. I woke up early in order to review my presentation, finish it up. 5:30 as a matter of fact, and got dressed, went out to my garage, and the garage door wouldn't open. As a good new power practitioner, the first thing I did was Google it, right? So I Googled, why won't my garage door open? There is no entrance to the garage in my house other than the garage door, and anyone who lives in a neighborhood area like Shaker Heights knows that garage windows are always painted shut, so you can't open those and crawl through. So I found no solutions on the internet, so I went from new power to old power. I woke up my wife. She, in fact, had been there when the garage door was installed, knew where the key was. I tried the key, and I couldn't make it work, but my wife tried it, and she made it work. That's old power. So new power and old power, complementary. When one doesn't work, we can use the other. The point is, in public health, without really recognizing it, we've been more about old power than new power. And new power is much more inclusive and represents an opportunity for us to make change with fewer resources. As one of the really important things about new power is the ability to act with fewer resources. So I suggest this as part of the approach to precision public health. I'll briefly comment on some of the work we're doing now with Health Data Matters. There is a need for an open source resource that provides health data to researchers in the community, permits hyperlocal assessment of diverse health, social, and economic data, place-based evaluation. Our analyses are place-based. We map out our findings, and this is all about precision public health. Our program allows for data sharing and promotes interoperability and provides a platform for data visualization, data mapping, and storytelling. We have a number of partners, many of them in this room, and our current work includes emphasis on broadband as a social determinant of health, and essentially digital redlining as something that impairs the ability of the opportunities of people who live in certain areas in Cleveland and other cities and in rural areas. The association between redlining and current health outcomes. We've done a recent study that digitalized redlining for Cuyahoga County and allowed both mapping and statistical analysis of the relationship between redlining and current social, economic, and health outcomes. We hope to be adding child health data through Better Health. We're in the process of working with them on that now. We have added the youth risk behavior data by zip code and are working on our first proof of concept projects for the youth risk behavior data survey, which of course comes from the Prevention Research Center here, and the use of health data mapping and visualization in health science education. In other words, we use this in our teaching and hope to be introducing students more and more to the public health triple aim and precision public health. The focus is on spatial epidemiology, and joyfully the department is in the process of recruiting spatial epidemiologists as part of our faculty. So I'm going to give a quick example. Let me check my time. Yeah, I'm good. Quick example, maybe I won't make it so quick because I've got time, of this complementary reciprocality that I described earlier. We did a study through the Research Association for Public Health Improvement, a public health practice-based research network here in Ohio, looking at the difference between community health network assessments, which are now required by the ACA and the IRS, of all hospitals in order to maintain their tax-free, tax-exempt status. They have to conduct community health needs assessments every 3 years. They are also required to implement create implementation strategies, which have not really materialized yet, as you'll see in this presentation. The point is that community health benefit dollars have largely been spent on what's referred to as charity care, and one can look at it as charity care. The other way to look at it, however, is writing off their bad debt. And a number of people recognize that this was not a substantial benefit to improve the health of the community, and requirements change. So we abstracted data from all 110 community health assessments done by public health departments, led by public health departments in Ohio, and in the same year abstracted 171 hospital community health needs assessments, and we compared their priorities and the quality of the approach that they took. We sorted the priorities into these four categories: medical conditions, health behaviors, community conditions, and health systems conditions. And these were the top 10 combined hospital and health department priorities that were identified. Good priorities: obesity, access to medical care, physical activity, addiction, mental health, nutrition, substance abuse prevention, access to behavioral health care, diabetes, heart disease, tobacco, and infant mortality were the top 12. But
what years were these reports?
2014. Thank you for asking. This represents the difference in top 10 priorities between hospitals and health departments, and you'll see that 6 of these categories were shared but placed in different order. So obesity was at the top for both. Access to medical care was there for both, but higher for the hospitals than for the health departments. And you can see admirably, hospitals did pay attention to mental health and addiction, but they paid attention to mental health treatment and treatment of addiction, not to prevention of substance abuse or youth development in schools, access to behavioral health care that really might make a difference for mental health. So when we look not just at the priorities but at the categories, this is what we see. Hospitals endorsed 39% of the health of the medical conditions, and only 1% of the community conditions in terms of their priorities for change. Public health endorsed health behaviors much more often. Community conditions much more often, and it was equivalent between health and hospitals and public health-led analyses in terms of the health systems changes. This is really significant. This is the reciprocal complementarity that I was talking about. I'm not saying medical conditions shouldn't be attended to. I'm saying if all we're doing is attending to the medical conditions, we'll have a lot more medical conditions. If we're not attending to the community conditions, if we're not attending to the health behaviors, we'll have more and more and more and more medical conditions that we need to prioritize, just as we do today, because we didn't do that yesterday. Recently, we did the same thing for state health improvement plans and looked at the same categories in terms of how hospitals, health departments, and state health departments prioritized these categories. And I'm giving you the broad sweep now, but in essence, that table isn't exactly right, sorry. The health behaviors diagram isn't exactly right, but in essence, state health departments were intermediate between health departments and hospitals in terms of how they categorized their priorities. And these were the top 10 state health priorities. I'll hold them there briefly. You can see the category that each of them fit. And importantly, in this study, we also identified the 10 lowest state health improvement plan priorities. Safe sex, the lowest. Domestic violence, next lowest. Youth development, health systems infrastructure, public health funding, health and safe community environments, dental access, violent crime. These are the lowest SHIP priorities. It virtually guarantees that there will be no state attention to any of these issues. These issues are our issues. These are the issues that matter to most of the people in this room. Lowest priorities for state health departments on a national basis. We're also looking, as we move towards precision public health, at the difference between old geography and new geography. Old geography, these are the census tracts that we generally do our analyses in, but census tracts, of course, are artificial borders. So we're looking at the development of new geography as well. Because of the overlap of health problems across census tract borders, we have the capacity to redraw where the areas of highest impact are for health problems, particularly what have been described as syndemic problems. Syndemic problems represent a situation where more than one problem combined together to create a greater problem. So the opioid epidemic in Ohio and the U.S. is a great example of a syndemic where pharmaceutical companies bringing new product into the field, hyper-marketing the new product, unlawfully marketing the new product, combined with the increase in chronic pain in our society and so on and so forth. That combination of things resulted in the opioid epidemic, and that syndemic status of the opioid epidemic is what makes it, like many of our health problems, so much more complicated and difficult to manage. But being able to cross borders and tailor interventions specifically to the newly identified area of concern is part of what we envision as precision public health. So, what are the implications for reinventing the ecology of healthcare? This is happening. There is a shift from healthcare to self-care. There is a shift from visit care to virtual care. There are expanded healthcare settings from minute clinics and pharmacies to primary care settings in Walmarts. Wearables are part of the information that are available to us and trackable. Group visits are increasingly prominent and effective, and precision medicine. All of these are part of reinventing the ecology of healthcare. As we reinvent the ecology of public health, and those represent a paradigm shift for healthcare, we need to attend to online health data, including Internet of Things, precision population health, precision public health, health and equity in all policy, disruptive community interventions, not exclusively new power, but like new power approaches, and disruptive technologies such as surroundables. This represents a potential paradigm shift for public health. Let me give a brief example of the project that we're currently working on that will help you get a better sense of what we mean when we say public health surroundables. We're working with commercial off-the-shelf voice assistants to think through what we might ask those voice assistants to recognize in order to improve public health and health surveillance. An easy example is that if we simply teach Alexa, Google Home, Siri, your smartphone, to recognize a cough or a sneeze, it changes the epidemiology of infectious disease forever. If we train it to recognize snoring, we suddenly have a new way of screening for obstructive sleep apnea. If we train the voice assistants to recognize a help word from a victim or person at risk for domestic violence, When the help word is used, a series of Internet of Things events can occur to protect that person, including but not limited to voice or video recording, everything that happens from the moment that help word is used, to calling 911, to locking doors, flashing lights, or locking a gun cabinet, to situations in workplaces of sexual harassment, to social settings where sexual assault may occur, being able to use that same help word and move from the he said, she said tragedy that represents sexual assault and sexual harassment to a recorded version of the event that occurs may change the culture of domestic violence and the culture of sexual harassment through technology rather than through goodwill or good wishes. So we have a planning grant working on a project we call Virtual Advocate that represents an example of how surroundables can be used to protect the health and well-being of a population. And we see all of this as part of the public health innovation that is changing the ecology of healthcare and includes precision public health. Thanks for listening. That's what I came to say.
Well, Scott, that was fantastic. Really, really good. And clearly, I mean, standing room only, people are actually behind there and they can see us.
Hi back there.
So we have some audience members in the back. But I'll kick off with one question and then open it up to the group. You know, one thing that I think in listening today is how do you get more than 3% of the funds focused in public health? And so as an example, Affordable Care Act, a lot of us celebrated Affordable Care Act as this major victory. And it is for health care. And I think, you know, one of the challenges is this fight of like, we want to keep that, but we also want to advocate sort of that complementary reciprocity that you're talking about. I mean, how do you raise the collective voice to try and get more funds allocated to support public health?
So the most likely answer to that question is we won't. But you know, it is the motivation behind articulating a public health triple aim. There is no question that resources were reallocated after the healthcare triple aim was described in ways that more effectively allowed places like the Better Health Partnership to utilize those funds to make real changes here in Cuyahoga County in health equity, in improving primary care quality, and making a difference. You know, we've been talking with Better Health for probably a decade about how that can expand into the community, and the child health data is part of that whole picture. But a lot of discussions have happened, and I don't think anyone would say that we've gotten there yet. But articulating this public health triple aim and placing it in its complementary position to the healthcare triple aim, we hope will open up funding resources that acknowledge that the healthcare triple aim will be better met if, in fact, a public health triple aim is attended to. And perhaps the earliest low-hanging fruit is the community benefits issue. That's why I had that emphasis on that today. Hospitals have to use funding. What did we say? $24.6 billion a year. $24.6 billion a year is what the community benefits are worth to hospitals. Maybe slide a few of those dollars our way, and if policy, in fact, requires hospitals and health departments to work together, as is the case in Ohio right now, then things can happen. One of the consequences, I won't claim that it's a direct consequence, but I have no question that it contributed to a change in state law. The analysis we did of community health department-led community assessments and hospital-led community assessments, showing those differences, in part led to a law in the state of Ohio that now requires several things. One, that hospitals won't meet their community benefit requirement if they don't work directly with health departments. Number two, that health departments in the state of Ohio, and in the only state in the union, are now required to be accredited, and accreditation requires community health assessments. So there will be no health departments that don't have community health assessments, and a shift of the health department requirement from a 5-year requirement for community health assessment to a 3-year to match the periodicity of the hospital approach. So if, in fact, we can work together, identify complementary community needs, if we went back to that slide of the priorities, obesity was at the top for healthcare, but for public health, obesity was second, but nutritional status in the community, the environmental factors related to obesity were part of what we refer to as the obesity cluster. We analyzed these not just by the categories that we started with, but by clusters that cross categories for things like obesity and chronic disease and so forth. Yes?
How about instead of an us versus them approach to a joining them approach? The first and only School of Medicine and Public Health at the University of Wisconsin-Madison has an extremely powerful public health component, all the way up and including Nobel Prize winning by the leaders of the public health department, and very vocal nationally and all the way to the United Nations.
I vote for that. In fact, I hope that was the emphasis of my talk, was the joining and not us against them. I will share a story when our previous dean, Ralph, whose last name I'm already forgetting, Horowitz was dean. He actually sent a memo out to faculty and alumni suggesting that we rename the School of Medicine and Health. I sent an email back to Ralph saying, I think that's a great idea, except I think I'd probably name it the School of Health and Medicine. He didn't like my suggestion. Neither did the faculty, neither did the alumni, and it never happened. So that was probably 15 or 20 years ago now, that it did come up and was rejected in the same sort of way that when Case went to call itself Case instead of CWRU, the alumni revolted, and we're now CWRU again. I do love the idea, and I applaud Wisconsin, who I agree does great work for doing it. In fact, the County Health Rankings program run at the University of Wisconsin is a true application of precision public health, except they just take it to the county level. We're big believers in hyperlocal data, so looking within counties to see where the problems are, not just looking at the broad scope of counties per se. Yes?
I think that's especially significant when you look back, I don't know if it's 40 or 50 years or whatever, but when John Renner went to set up the Department of Family Medicine, he had to go around the university, around the medical school, and go directly to the state legislature to get a line item for family medicine, which I think is a step closer than it had been to this approach.
So I'm an old guy, so I am a member of the very first residency class of family medicine ever at the University of Michigan. I'm often called back to the University of Michigan to give talks about that experience, and just as you've implied, Michigan refused to have a Department of Family Medicine until the state said they would withdraw all state funds if they didn't have a department. I went and met the chairman of the new Department of Family Medicine, Terry Davies, in his brand new office, which was next door to the monkey labs in the basement of University Hospitals at the University of Michigan. And he still talked me into doing family medicine. Best decision I ever made for me personally. And then expanding to public health was an extension of that. Other thoughts or questions? Yes.
So Scott, I don't actually, this is a devil's advocate issue. So I always think about it, how
Elaine as devil's advocate? I can't imagine.
But you'll see why. So, because I'm always struck by the wearables and all of that. So it's interesting, as you were saying, I was like, wow, that would be cool, this and that. And suddenly I'm thinking, I don't want Alexa to know if I'm snoring. I don't want to know. Like, so how do you think about that? Because when it comes to public health, it seems a little bit more not,
So that is what we're thinking about. I hope you'll be happy to know. In our planning grant that we're doing this year, we're looking at both legal and ethical issues, and clearly this would be framed as an opt-in. So, if you don't want Alexa to know you snore, you don't opt in. But if you opt in until you opt out. And if you're not at risk for domestic violence or sexual harassment, you don't have the virtual advocate app, but other people who do feel they're at risk do have it. A graduate of our program, pardon?
Is it a slippery slope?
Is it a slippery slope? Yes. I sometimes, late at night, imagine that the Terminator's coming back for me now. The idea of surveillance by the things that surround us. I do believe that there are outdoor surveillance things like lighting, street lighting, CCTV things that may be able to be built into the surroundables concept. But in terms of what happens in our own home, the key is to make it opt-in, and the implications are enormous. Apartment buildings may build in the virtual advocate and advertise that this is a place for safety. The idea of doctors prescribing the virtual advocate to their patient who they know is at risk for domestic violence. The irony is that right now, many doctors are virtually forced to ask if you feel safe at home, but have no idea what to do if the patient says no. How about if we can prescribe the virtual advocate for them? These are the kinds of things that we're looking at, and whether it ever comes to fruition, we don't know. But I would say it's a dialogue worth having. Yes?
Wanted to mention, my grandmother lives in a community of seniors, and they all wear those buttons. Mm-hmm. And that reminds me a lot of the virtual advocate. What if your Alexa at my grandma's house could help call 911 if she says call 911?
So we're ahead of you on that. One of the virtual advocate, one of the Internet of Things projects funded by CASE along with ours is in a nursing home, and they essentially have a lab in the nursing home that will allow us to place these surroundables in the position where elderly are in a nursing home, but even more so to protect them, to help them stay at home longer, to be able to use the virtual advocate, and for the elderly would be good. I am just reminded, I don't know how many of you have seen, and if you haven't, I really encourage you to look it up. The SNL skit on virtual advocate, on Alexa for the elderly. It's hilarious and way too accurate. So, it has to be built in a foolproof kind of way. Yes?
I was wondering if you think it's naive, going back to the thought of how to align goals of, sort of medical care.
Yes, it's naive.
Health. Do you think it's naive? Because the way I've thought about it is with precision, the advent of precision medicine, which I think more of not just molecular stuff, but rather just the advent of big data, right? Mm-hmm. And being able to tailor things more precisely, using data at all levels. So do you think it's naive to think that maybe that opens up an opportunity to sort of medicalize prevention? In other words, it seems to me that, you know, the reason medical care is so focused on certain aspects, it's because you can reduce them to something that you can then, you know, try to measure and treat. And now, you know, we can do that prevention-wise as well, because we can define at-risk groups in finer and finer ways, you know, in a preventative way. So maybe I'm thinking about the medical care sort of approach where, you know, you have a market. If this medicalizing of prevention can open up the market to the 900 part of the pyramid, it would seem that would be an incentive for medicine,
yes.
For medicine. Now that
for medicine to co-opt public health.
Exactly.
Yeah. Yes, that's also a slippery slope and a risk. My personal take on it is, number one, it'll never pay as much as other ways to practice medicine. And number two, at least as medical students are trained now, they're not trained or inclined to take that sort of focus. There is a smaller cohort who mostly enter primary care who do have that inclination and will not co-opt public health, but will work with public health. You know, I think what you're describing is, will this become disruptive enough and of high enough income generation so that it could replace some of the things that we probably still will be doing better in public health than they would be doing in medicine, but they get paid more to do it. Yes, I think that's possible. Yes, I think that's part of what we have to protect against as we seek to move these things into the mainstream. And yes, that's why we've described a distinct public health triple aim from the healthcare triple aim. Yes?
So just briefly back to the virtual assistants. Alexa and wearables, those are not cheap. And then I would argue that some of the populations that are at the highest risk of things like domestic abuse maybe can't afford those. So how do you mitigate?
So we do agree with you fully on that. That's why, for example, we would be looking to create a system where anyone who receives a protective order from the court also receives a virtual advocate. Anybody who files a complaint of domestic violence or a call comes from their home for domestic violence is given by the court system a virtual advocate. And I would say that despite the cost issue, even in poverty areas now, the smartphone is predominant. And we're not looking to use just the voice assistants, but your smartphone, because you're not taking your Alexa to your workplace. But if your phone can also be taught to listen for your help word, and somebody's in your office saying things or doing things that are threatening, you know, you've got the option of simply saying, I've just activated my virtual advocate and is recording everything that's being said now. You may want to consider what you say. So you could use it preemptively, or you could use it to support your complaint and just let the event proceed until a point that you cut it off so that you have the evidence of the encounter. So smartphones is part of the answer, distribution by doctors, and the judicial system we see as part of the answer as well. All of that is still inhibited by the digital redlining that creates other issues for use of these technologies in certain areas of Cleveland and rural America.
And that is a huge problem. Access to the internet alone is a huge problem. You go 100 miles from here and probably just spotty and unaffordable if you want to have broadband. So how do you reverse the state trends to basically not care about public health? I mean, do we have to think broader than Cuyahoga County? Because what we have right now is kind of a city versus rural environment. But the problems in rural Ohio are just as great, but it's kind of like an echo chamber, right, that occurs there. So do we need to think beyond, reaching beyond just Cuyahoga County and the cities in Northeast Ohio, and start using the new power in rural America to maybe show up at some festivals, or, what's Cleveland doing down here? Well, we're the same as you. And, because the only way you're going to get real change, we have one of the lowest funded public transportations in the nation, right? So people can't get to the doctor because they'll miss work. They can't get to their job,
They may have to travel an hour to get to the doctor.
The system is so stacked against
Rural America.
Well, against this community as well, right? So what I'm trying to think is public health has to go, I think, beyond just...
So there's no question that public health needs to do that.
I don't have the solution.
Doesn't mean I need to do that. What I care about right now is Cleveland, and reaching those areas in Cleveland that are in desperate need of support. And if we do proof of concept here in Cleveland, then we have an opportunity to export that proof of concept out to other urban areas and apply the same principles in rural areas. The public health triple aim is every bit as applicable in rural areas. In fact, more applicable. It's more applicable the fewer the resources are. We see these things supporting under-resourced populations everywhere. My personal interest is in my home.
We're going to take that as the last question because it's right at our time, but I'm sure Dr. Frank would be willing to stick around for a few minutes, although it is his vacation day, so not very much longer. And join us in applauding Dr. Frank.